Hello guys. I am Dr. Rahil Gohar. I am a consultant neurosurgeon in the public sector in Pakistan. So today we are going to discuss about the anatomical landmarks of the cranium, or we can call them the craniometric points. These are very important in terms of your theory as well as for practical purposes, because we are going to use these landmarks to identify some of the points which we are going to use during surgical procedures. So let's begin with the normal anatomy. So first of all, I want to discuss about the anatomy of the bones, which we all know, but let's discuss it in a summarized form. So this purple bone shown here is the frontal bone, and this bone here, it is making a joint with these two nasal bones. This joint is known as the frontonasal suture. This is important as we are going to discuss later. Then when we are seeing the lateral view of the skull, this process of the frontal bone is known as the zygomatic process, because it is making a joint with the zygomatic bone of the zygomatic bone of the skull. Then this here is it is a suture between the zygomatic process of the frontal bone and the zygomatic bone. This is known as the frontozygomatic suture. Then in the pink color is shown the parietal bone. In the light blue color we have a part of the sphenoid bone which is known as the greater wing. Then we have this green color bone which is known as the temporal bone, and the occipital bone here shown here. The temporal bone has many parts, but two of the parts are shown here. This part here is known as the zygomatic process of the temporal bone, which is making a joint with the zygomatic bone. And here this triangular structure is known as the mastoid part of the temporal bone, or the mastoid process as well. Now moving towards different sutures, I have already discussed the two important sutures. One is the frontonasal suture, and another one is the frontozygomatic suture. Now these are four important sutures which will help us in identifying different landmarks, different surgical points as well. So this is a suture in between the two parietal bones. This is known as the sagittal suture. Anteriorly, you can also see one more suture which is connecting the frontal bone with the two parietal bones. This suture here is known as the coronal suture, and over here this suture meets the sagittal suture. This point of connection is known as breccia. From the anterior view you can see this is the coronal suture. From the lateral view we can again see this one is the coronal suture. Now here you can see that all these sutures are meeting at this point. This point is known as Pterion, which I am going to discuss later as well. But the point of showing it here is that the coronal suture is starting from this point and it is going upwards from there. Here you can see this is the squamous part of the temporal bone and this is the parietal bone. So a suture between them is known as the squamous suture. Then this is very important suture here. It is a V-shaped structure. It is known as the lambdoid suture. And this lambdoid suture is in between the occipital and the two parietal bones. This lambdoid suture is meeting here with the sagittal suture, and this point of meeting is known as lambda. So in this picture you can see all the sutures together. It is very important. Then we will move towards our craniometric points. So again, this is the frontal bone and the parietal bone, and this is the coronal suture. Between the two parietal bones, this green suture is known as the sagittal suture. Between the occipital and the parietal bone, this one is the lambdoid suture. Between the squamous part of the temporal bone and the parietal bone, we have this suture which is known as the squamous suture. Now there is one more suture here shown here in the light blue color. So it is known as the frontosphenoidal suture. So this is the frontal bone and this is the sphenoid bone. The suture between them is known as the frontosphenoid suture. I have already discussed two more sutures. One was the frontozygomatic suture and one was the frontonasal suture. Let's begin with these craniometric points: nasion, glabella, bregma, vertex, pterion, asterion, inion, superior and inferior temporal lines, opistheon and basion. So this point here, as you can see, this is the frontal bone. It is making suture or connection with these two nasal bones. This is known as the frontonasal suture. The most prominent point of this frontonasal suture is known as the nasion, as shown in this with this yellow point. Then there are two superciliary arches above the orbit, and between these two superciliary arches, these are this red point. It is known as the glabella. This nasion is going to help us find one very important point, which is known as the Kocher point. Then again, I have already discussed about this. This is the coronal suture, this is the sagittal suture, this is the lambdoid suture. And the connection point of the coronal and the sagittal suture is known as the bregma. The connection point of the lambda and the sagittal suture is known as lambda. In the lateral view, you can see this is the bregma, and 2 centimeters behind the bregma, we have a vertex. Now, the two very important points, one is known as pterion and one is known as asterion. The pterion is this H-shaped structure shown here, and different sutures are meeting here to form this structure here. It is known as the pterion. 4 bones are meeting here: frontal bone, parietal bone, greater wing of the sphenoid, and the temporal bone. It has a pathological significance that this part here, which is known as the pterion, it is the thinnest part of the skull, of the vault of the skull, and whenever there is a blow to the lateral side or the temporal region, these bones get fractured. Below this bone or this point, there is an artery which is known as, there is an artery which is known as the middle meningeal artery, which is going above the dura, and whenever there is blow to this area, this pterional area, it gets fractured and it ruptures that artery, results in the formation of extradural hematoma. So this is the pathological significance of this point. Then another point is the asterion. As you can see, this point here is the asterion. 3 main sutures are meeting here. One is the lambdoid suture, which we already know. One is the suture between the parietal and the mastoid bone, which is known as the parieto-mastoid suture. One is the suture between mastoid and the occipital bone, which is known as the occipito-mastoid suture. So these 3 sutures are meeting at one point, and it is known as the asterion. Then from the posterior view of the skull, we have a prominence which is known as the external occipital protuberance, or we can also call it as inion. From inion, 2 lateral lines are going laterally, and these are known as the superior temporal lines, so superior nuchal lines, and different muscles of the neck are attached here. Then we have inferior nuchal lines as well. Now, on the lateral view of the skull, we already know about the zygomatic process of the frontal bone. So if we follow this process superiorly, it divides into 2 lines. One is the superior temporal line and one is the inferior temporal line. Now, the inferior view of the skull, you can see this very large opening. It is known as the foramen magnum. It is the largest foramen of the base of the skull. Laterally, you can see these 2 condyles, which are known as the occipital condyles. These are going to make joint with the first cervical vertebra. Now, this foramen of magnum is marked by 2 points. One is anterior and one is the posterior point. The anterior point is known as the basion, and the posterior point is known as the opisthion. As you can see in this section, in this lateral view as well, this one is the basion and this one is the opisthion. So these are the anterior and posterior boundaries of the foramen of magnum. Now, after these craniometric points, we have to know some of the lines on the skull, and with the help of these lines, we are going to identify the different cerebral structures inside the skull. Now, why this is important? Because, for example, if we are going to perform a craniotomy on a certain part of the brain, and for example, there is a tumor in the anterior to the motor cortex. Now, before performing the craniotomy, we have to know where we have to perform the craniotomy. So with the help of these lines and with the help of all those craniometric points which we have discussed, we are going to make our craniotomy. So let's discuss these lines as well. These lines are known as Taylor-Haughton lines, and we can construct them on the skull. We can construct them on different radiological investigations like the angiogram, CT scan, MRI, or X-ray skull. So starting with the Frankfurt plane is shown by this red line here on the lateral X-ray, on the lateral skull. So you can see that it is starting from the inferior orbital margin and it is going from above the external auditory meatus. Then there is another line which is known as the Reed's base line, which starts again at the inferior margin of the orbit and it is going to the center of the external auditory meatus. These are 2 very important lines. Then there is one more line which is known as the posterior air line. So this is the external auditory meatus. Posterior to it, we start a line from the tip of the mastoid and we are going upwards till the surface of the surface of the skull here upwards. So this is known as the posterior air line. Then this structure here is the mandible, we all know. one of the process of the mandible is known as the condylar process, and we draw one line above from the condyle above, and it is known as the condylar line. There is one more line which is known as the nasion-inion line. We know the point nasion, we know the point inion. So we draw a line here from nasion till the inion. This is known as the nasion-inion line. Now, before we can identify different cerebral structures with the help of these lines and these landmarks, let's review some of the anatomy of the cerebrum as well. So we all know that the cerebrum is divided into frontal lobe, parietal lobe, occipital lobe, and the temporal lobe. And there are two main sulci. One is known as the central sulcus and one is known as the lateral sulcus. The central sulcus is a dividing line between the frontal lobe and the parietal lobe. And interior to the central sulcus, this gyrus of the frontal lobe is known as the precentral gyrus, or it also called as the motor cortex. This is actually controlling our voluntary activities. Then posterior to the central sulcus, it is known as the post-central gyrus. Very simple. And it is a somatosensori cortex. All the sensations of our body are going there. Then we have this lateral sulcus. It is also known as the silvian sulcus, silvian fissure, and this is very important as well. So with the help of all those lines which we have discussed, with the help of all those landmarks which we have discussed, we are actually going to perform our different surgeries on the skull, and with the help of those landmarks we can identify where we are going to land inside the skull. Well, before moving towards that, let's discuss one or two lines more. So these are two more lines. One is the orbitometal line. So you can see that orbitometal line is different from the Frankfurt plane and the Reed's line because it is starting midway between the orbit, or we can say from the lateral canthus, and it is going midway to the external auditory canal as well. Then there is you can see from the external auditory meatus we are drawing one line and it is going 6 cm above it. So this point is known as the Chatter's point. Remember this point. Now this here orange line, it is showing the nasion-inion line which we have already discussed. Usually whenever we are discussing this line, always remember that we are going to divide it into different parts. So 1/4 is a 25%, then midpoint of this line which is the 50% or 1/2, then 3/4 which is the 75%, and then finally the 100% of this line. So we divide it usually into 4 parts. Okay. Now how we are going to use this line to identify the silvian fissure, motor cortex, central sulcus? Let's begin. So first of all, the silvian fissure. We have already discussed about one very important suture which is known as the squamous suture, which is a suture between the temporal bone and the parietal bone. So if we have exposed the temporal area, just identify the suture, and the silvian fissure is actually running along this line. Simply, first way of identifying the lateral sulcus is to identify the squamous suture. Now the second way, you divide the nasion-inion line into 3/4 or the 75% point and mark it. Then you draw a line from the lateral canthus and you join this line with the 75% of the nasion-inion line. This is actually representing the silvian fissure or the lateral sulcus. So these are 2 points. Now the third way is to join this line starting from the lateral canthus and join it with the Chatter's point. This is also represented the silvian sulcus. So these are 3 ways with the help of which we can identify on the skull where the silvian fissure or lateral sulcus is. Now moving towards the central sulcus. Now as we described how to identify the silvian fissure by 3 ways, we have 3 to 4 ways to identify the central sulcus as well. Now for example, you have exposed the skull. Now first of all, identify the coronal suture. If you go 4 to 5 cm behind the coronal suture, there you identify the central sulcus. So you can roughly say that the central sulcus is 4 to 5 cm behind the coronal suture. So this is first one way. Now the second way, simply just draw a 5 cm line above the external auditory canal, as you can see here. Then divide the nasion-inion line into 50-50%. So this is the midpoint of the nasion-inion line, and from 2 cm behind this line, start to draw a line and join with this 5 cm line above the external auditory meter. This line here, which is shown in the yellow color, is actually representing the central sulcus. Then there is a third way as well. This is the posterior line we already know, starting from the tip of the mastoid and going upwards. Then this is the condylar line. Okay, this is the silvian fissure line we already know. So what you have to do, where this condylar line is meeting with the silvian fissure line, you draw a line from here and join it with the posterior line. Now this line is representing the central sulcus. So these are the three ways with the help of which you can identify on the skull where the central sulcus is. Now anterior to the central sulcus we have the motor cortex, and posteriorly we have somatosensory cortex. It is this simple. Now this here we are going to discuss about the anatomy of the ventricles. Now there are many conditions in neurosurgery, and the one very important condition is the hydrocephalus. For hydrocephalus we have to gain the intraventricular access, and we perform two of the procedures. One is the external ventricular drain, which is a temporary drain, and then which is used for both the therapeutic purpose to reduce the ICP and also to monitor the ICP, intracranial pressure. Then there is another way, another thing which we do, which we perform the ventriculoperitoneal or pleural or ventriculoatrial shunts in case of hydrocephalus. Now, in developing countries like ours, in Pakistan, in public sectors, we do not have a system of navigation. So we usually gain the intraventricular access with the help of these landmarks. So let's discuss the anatomy, and then we are going to identify the landmarks and the surgical points where we can access these intraventricular areas. So this is the coronal view, and you can see these are two lateral ventricles. Then this is the third ventricle. This is the cerebral aqueduct, which is a connection between the third and the fourth ventricle. And then finally, the fourth ventricle is opening into the subaqueous space via these foramens. Laterally, you can see these are the lateral ventricles. So lateral ventricle is divided into the different parts. These are the frontal horns of the lateral ventricle. These are the occipital horns. These are the temporal horns, and this is the body of the lateral ventricle. Then this here structure shown here is the third ventricle, and the third ventricle is connected with two lateral ventricles via these foramens, which are known as the interventricular foramen or the foramen of Monro. Then this one here is the fourth ventricle. The fourth ventricle is connected with the third ventricle via this aqueduct of Sylvius, or it is also known as the cerebral aqueduct. Then finally, the fourth ventricle is opening laterally via the foramen of Lashka into the subaqueous space, and via median foramen posteriorly, it is known as the foramen of Magendie. And then finally, the CSF comes into subaqueous space around the brain and around the spinal cord. Now, how can we access? So here, first of all, whenever we are performing the intraventricular drains or VP shunts, we have to know from the skull how deep we have to go to hit the ventricle. So usually when we are talking about here, from a Kocher's point, there is one point which is known as the Kocher's point. So from the Kocher's point, it is usually from the surface of the skull to the ventricle, it is usually 4 to 5 centimeter. Okay. Then here you can see this is the coronal suture. So coronal suture is marking if we mark coronal suture laterally on the skull, so it is actually marking a boundary of a ventricle, means some of the ventricle is anterior to the coronal suture. So if we know where the coronal suture is, we can identify that there is a part of the ventricle which is anterior to it, and there is a part of the ventricle posterior to it. So there is only 1 to 2 centimeter of the lateral ventricle which is anterior to it, which is also known as the frontal horn of the lateral ventricle, which I have already discussed. Now these are the important points, all those lines, all those landmarks which we have learned. So we are going to utilize those points to identify these important points so that we can perform our surgery. So starting with this point which is known as the Kocher's point, which I have already discussed twice. So what is Kocher's point? Kocher's point is a point on the surface of the skull with the help of which we are going to get the intraventricular access. Either we are going to perform the EVD, which is known as the extraventricular drain, or we are going to perform a shunt, maybe ventriculoperitoneal or pleural, or maybe ventricular atrial shunt. So this point here is known as the Kocher's point. So this is the nasion we have already discussed, and in the midline we are going to follow this line posteriorly from the nasion 11 to 12 centimeter, 11 to 12 centimeter behind the nasion, and 2 to 3 centimeter lateral to the midline. This point is known as the Kocher's point. We can also identify this point in another way. We are going to mark the mid-pupillary line here like this until it hits the coronal suture, and then we are going to go 1 centimeter to 2 centimeter anterior to the coronal suture, and this is the Kocher's point. So with the help of the coronal suture and nasion, we can identify the Kocher's point, and from there we are going to go medially and posteriorly to hit the lateral ventricles. Okay, so this is the Kocher's point. Now There are two more points which are known as the Keen's point and the Fraser's points. There is one more point which is known as the Dendy's point. I'm going to discuss it as well. So what is Keen's point and why are these points used? These points are also used to gain the intraventricular access. So this is a Keen's point. It is 3 centimeter above and behind the femur. This is known as the Keen's point. Then with the help of the inion, we go 3 centimeter lateral to the inion and 6 centimeter above it. This is known as the Fraser's point, with the help of which we can get the intraventricular access. So these are two more points to gain the intraventricular access. Then there is a point which is known as the McCarthy's point or McCarthy's burr hole. Now, when we are performing different surgeries, there is an approach which is known as the pterional craniotomy. Also, there are different approaches as well, but there is a craniotomy which is known as the pterional craniotomy. The first burr hole for that craniotomy, and also for orbitozygomatic approaches, the first burr hole is known as the key burr hole or the McCarthy's burr hole. This burr hole is important because with the help of this burr hole, we can gain access to the intracranial cavity as well as the orbital cavity. So here you can see we have already discussed about the frontozygomatic suture, which is represented here, and frontosphenoid suture, which is represented here. So if we have to identify the frontozygomatic suture first, and we are going to go 1 centimeter behind it on the frontosphenoid suture, and we are going to make our first burr hole here for the pterional craniotomy or the frontozygomatic craniotomy. And this is known as the McCarthy's burr hole or McCarthy's point. This is very, very important. Also, one point which I have not written here, but I want to discuss here. This is the temporal bone. This is the zygomatic process of the temporal bone. So when a patient comes to you with trauma and also for other approaches, whenever we are going to include the temporal area in our cranial, for example, a patient has come to us with a very large EDH, and we are going to perform a trauma flare, which is a question mark incision. So first burr hole will be made here at the temporal lesion, and this will be made above the zygomatic process of the temporal bone here, and then we are going to perform our other burr holes, and we are going to perform our craniotomy. Now, asterion, I have already discussed about the asterion. This point here where three sutures are meeting. One is the lambdoid suture, one is the parieto-mastoid suture, one is the occipito-mastoid suture. So this point is known as the asterion. It is a significance that the transverse sinus and the sigmoid sinus is meeting at this point. Now, whenever we want to gain access for CP angle tumors, the cerebropontine angle tumors like vestibuloschwannoma, like the CP angle meningioma, like pterional meningioma. So whenever we are going to gain access for these tumors and other tumors as well, we want to perform a craniotomy which is known as the retrosigmoid craniotomy. Means behind the sigmoid area and in the occipital area, but infratentorially. Infratentorial means there is a tent shaped structure which divides the cranium into, means cranial cavity into supratentorial compartment and infratentorial compartment. So retrosigmoid approach is for the infratentorial compartment, and we are going behind the sigmoid. So how to approach that area without damaging the transverse and the sigmoid sinus? So we have to identify the asterion, and after identifying the asterion, we are going to make our first burr hole 1 centimeter medial, 1 centimeter inferior to it, and here. Then we are going to perform the craniotomy or craniotomy, and then we are going to go inside to make our surgical approach. So this point is known as the asterion. I hope that you must have understood everything. I'm going to make other videos on different surgical approaches on radiology, like CT scan brain plane, MRI brain plane and contrast, and other sequences of the MRI and other videos as well. So I would like that you support me, you like this video and you subscribe to this video as well, so that I can continue to make these amazing videos. Thank you very much.